In this video, we're going to talk about Tetralogy of Fallot. Tetralogy of Fallot is one of the most common congenital heart defects, and it has an excellent prognosis. Nevertheless, there are some long-term sequelae that are important to be aware of. To review, in normal anatomy, blood returns from your organs blue without oxygen. It goes to the right side of the heart. It gets pumped to the lungs, where it picks up oxygen, turns red, and then it goes to the left side of the heart, which then pumps it to your brain and the rest of your organs. Separating the right side from the left side is your septum. It's a wall. In Tetralogy of Fallot, there's a defect, there's deviation of your ventricular septum that kind of goes more anteriorly into the right ventricle. This leaves behind it a hole that allows for communication between blue and red blood. Now, additionally, there's some muscle bundles here that create a little bit of resistance to flow. So blood has a harder time going through into the lung arteries, and it's more likely to go leftward in certain conditions. Together, this can lead to dysfunction of the ventricle because it's having to pump against an obstruction, and it can also lead to low oxygen saturations in particular circumstances. Surgeons typically fix this during infancy. The way they do it depends on your particular anatomy. Generally, though, they close this ventricular septal defect, they close the hole with a patch, they resect these muscle bundles, and then based off the valve, they may leave it intact if it's working normally. Typically, though, it's underdeveloped and small, so they have to put a patch to enlarge this lung artery and the valve itself, or if it's too small, they may put a whole graft to replace the entire thing. This is an example of a patch repair. Here's the VSD patch that closed the hole between the right and left. And then here's a transannular patch that goes over where the valve used to be. This is an example of an RV to PA conduit, where they had to put an entire graft, a tube, replacing the outflow tract, and inside this there's a valve. One thing to keep in mind is that with a patch repair, whereas you have relieved the obstruction, putting in the patch actually messes with the ability of the valve to close completely. So whereas blood can flow forward, there's a lot of blood that actually leaks backward as well. You've traded one problem for another. That's okay because leakiness is much better tolerated compared to obstruction. However, it does mean that at some point in the future, you're going to have to change out the valve. And we typically wait till the child is older so that you can put a valve that's big enough that's going to last a longer time. So, what about long-term sequelae? I like to group this into three major categories: the valve, the rhythm, which is kind of like electricity inside the heart, and then the heart muscle. That's the function of this muscle right here, which works to pump blood outside the heart. So we've already alluded a little bit to the valve. We've mentioned how in Tetralogy of Fallot, the goal is to increase the blood flow going to the lungs. However, some of the repairs can lead to a lot of leakiness going backwards. And over time, because the heart has to absorb a lot of leakiness, this can cause the right side of the heart to dilate over time. It can get a lot bigger. Now that's okay because the heart can tolerate it, but past a certain point, if it gets too dilated, the heart becomes remodeled, it gets scarred, and then whereas initially it could be pumping very well, it can then become dysfunctional, and its squeeze can be a lot weaker. You want to fix this valve before the heart gets too big, before it gets past the point of no return, and before there's any dysfunction, and definitely whenever there's any symptoms that develop. There's two ways to do this. Either you fix it surgically, or in this day and age, we have transcatheter options that go entirely minimally invasive through the groin. Which one works better depends on your particular anatomy, and there's advantages and disadvantages to both. Next is your rhythm. Now, in a typical heartbeat, there are these pacemaker cells that send electrical impulses down to the rest of your heart, telling all the heart muscle when to contract. So it's contracting in a synchronous and irregular sort of way. Now, as you develop more scar tissue from heart failure as well as multiple surgeries, You can have these rogue cells that don't listen to the chief and they do their own thing. This can happen from the top chamber, but it can also happen from the bottom chamber. In the bottom chamber, these are typically re-entrant circuits. They're kind of like loops of electricity that form around areas of scar where the heart can beat very, very fast. This can be dangerous. It can lead to low blood pressure, heart failure, and then in extreme situations, sudden cardiac death. Thankfully, that's very rare. It's estimated to be about 0.15% per year for the general adult Tetralogy of Fallot population. However, some people have higher risk based off of their age, the type of surgery, and all their comorbidities. If you're sufficiently high risk, your doctor may recommend a pacemaker or a defibrillator, where you put one lead in the top chamber, and then you put a defibrillator, which has a coil, in the bottom chamber. This monitors your heart rhythm, and if you ever get into that dangerous rhythm from below, it can shock you out of it, potentially saving your life. Not everyone needs this, though. It's only those who are sufficiently high risk for ventricular arrhythmias. And then 3 is your heart muscle. Your heart muscle is essentially the squeeze of the heart as well as this relaxation. We've talked about if you leave the valve uncorrected over a period of time, that heart muscle can remodel. Instead of pumping vigorously, it can start to get weak. And in addition to the pump, there's also the relaxation of it. Damage to either will lead to further dilation of the right heart, bowing into the left side of the heart, leading to impaired filling. And then together, this could lead to things like shortness of breath, swelling, which is typically in the abdomen or the legs. These are symptoms of heart failure. So, in today's video, we talked about the initial anatomy, the defect in Tetralogy of Fallot, some of the ways that surgeons can fix it, and then some of the long-term sequelae that can develop. It's really important that, while you've had the surgery fixed, you are still at lifetime risk for these other things. So it's important to see an ACHD specialist who is well versed and familiar with these problems and knows how to manage them.